Michiel is a physiotherapist who works for the Christian Blind Mission. He trained in Netherlands and has lived and worked in Africa for over 23 years. He's currently working in Uganda, and I really knew of Michiel through his foot abduction brace, which is really well known all over the world because he designed a very low-cost Steenbeek foot abduction brace for little kids with club feet. So thank you, Michiel, for talking to us, and I will stop sharing.
Good day, everyone, and thank you for having me on this webinar. My name is Michiel Steenbeek, and I work with CBM, Christian Blind Mission, and I'm based in Kampala in Uganda. And indeed, I have nothing to disclose. CBM is an international Christian development organization committed to improving the quality of life of persons with disabilities in the poorest countries of the world. We work with and through partner organizations in the fields of community-based inclusive development, inclusive eye health, physical rehabilitation, ear and hearing care, inclusive education, livelihood, disaster risk reduction, and inclusive humanitarian action. By doing so, we indeed find ourselves active in austere environments, and I believe the images on the screen reflect that well. The World Health Organization estimates that only 1 in 10 people in need has access to assistive products, including prostheses and orthoses. And that is because of their high cost and because of lack of awareness, availability, trained personnel, policy, and financing. 65% of all amputees live in low and middle income countries, and around 90% of them have absolutely no access at all to prosthetic devices. Regarding the prosthetic and orthotic care in austere environments, I have to first mention the challenges faced in this field. Let's look at the supply side. To start with, and as you know, before a patient will see an orthotist or a prosthetist, the patient often needs to be evaluated by an orthopedic surgeon. We still have very few orthopedic surgeons in most of the lower middle income countries. If I'm well informed, then the ratio of orthopedic surgeons in the USA is about 1 to 10,000 population. In Uganda, with a population of around 47 million, the ratio is 1 orthopedic surgeon per 500,000 population. And that is certainly an improvement compared to about 15 to 20 years ago. Now back to prosthetics and orthotics. There are very few P&O schools, and some countries have no school at all. The majority of the schools lack ISPO accreditation, which has to do with the point that the curriculum and the quality is below standards. So we end up with quite a few graduates with little experience. They will not get much more experience because there are very few in-country or regional postgraduate courses available. And governments do not create many jobs in this field. The few government workshops that are in place are often poorly equipped and often lack components and consumable supplies. Orthotic and prosthetic components can be available through local suppliers or pharmacies. However, most components need to be imported, and in small quantities, the costs will be high in the given context. Then the challenges on the demand side. There's a direct relation between disability and poverty. Persons with disability and families with a child or children with disability tend to be poor. The attempt to seek then for an assisted device brings along transport costs, accommodation costs, and uncertainty about accommodation availability, as well as opportunity costs. In the given context, the final product is expensive. For example, in Rwanda, a below-knee prosthesis made with ICRC technology will cost about $390, while a below-knee prosthesis using more advanced technology and components will cost around $950. Then the cost for an above-knee prosthesis will be $650 up to $2,600 respectively. Now that may sound like a good bargain compared to the cost in the global north. However, in the context of low and middle income countries, it is unaffordable for most patients. In the meantime, there's also no community health insurance in most countries that is covering orthopedic assistive devices. Now let's assume that all those potential challenges and hurdles have been overcome. Most workshops apply conventional technology using plaster of Paris, then a negative taking is done, making a positive with subsequent modification, thermoplastic technology, or sometimes lamination. Prostheses tend to only have monocentric, sometimes polycentric knees, and that is it. There is no hydraulic or pneumatic or microprocessor controlled knees and feet, and so on. For low and middle income countries, the International Committee for the Red Cross, ICRC, has been instrumental over the last couple of decades. They introduced the thermoplastic polypropylene technology for P&O as a successor for the metal and leather and wood-based applications. It's a basic and functional technology and has been a game changer for many countries. As you will probably know, there is global interest to innovate and use 3D printing in many fields, also in prosthetics and orthotics. Some of the programs supported by CBM have been and are involved in this development to produce prosthetic sockets, orthoses, and insoles. Good progress is being made, and a few hundred devices are in use. It's not yet fully worked out, while we are waiting and observing the longer-term follow-up results. Certainly, it needs a different and a new type of management of a P&O workshop, and of course additional training, hardware, software, strict procurement routines with corresponding budgets, not all available in Africa all the time. Another development is the so-called direct socket technology, whereby a socket is fabricated with the lamination materials directly on the residual limb. Originally introduced by Austere from Iceland, but I have come across startups in a few sub-Saharan countries where this technology is applied in an adapted fashion. In conclusion, orthotic and prosthetic care is only accessible and affordable for the, let me call it, happy few, unless one donors, NGOs, community health insurance, and especially national governments step in. New technologies are emerging and are promising. Before I end, I apologize for mainly raising the aspect of prosthetics. Well, we all know that orthotics and adapted shoes are in higher demand, sometimes also orthoprosthesis, which was mentioned earlier. It's just that information about prosthetics is more readily available and often more visible. I thank you for your attention.